one of the first things that struck me about Oula when I was learning about your company was that you really emphasize that your providers listen to patients and make decisions with them, not for them. And so I would love for you to talk a little bit about why that's so important and different, and also how does that look in practice?
I mean, I think it's so important because we honestly have sort of a paternalistic healthcare system. So many things, frankly, about women's health. We are telling women what they should do with their bodies, and pregnancy care is no different. Where I think I look sometimes at the big proliferation we've seen of doulas recently over the past couple of years, and to me, it's always striking that you have to have someone in the room with you as your advocate, or else you're concerned something's going to happen to you that shouldn't happen to you. And so you see C-section rates that are 3 times what they are supposed to be. You see lots of really poor outcomes, and I think it all comes back to, at the core, we need to listen to women, we need to trust them, and so it is so core to what it is that we do at Oula. And part of our ability to do that is we just have longer appointment times. Sometimes it's not rocket science. You just need to spend time with patients to be able to have the real conversations and the dialogue that's necessary to deliver really great care.
Yeah. And something else that seems unique to Oula is more frequent touch points for patients instead of you have one scan at the beginning and whatever. Why is that important, and how do you make that work financially with the reimbursement that you get from insurance providers?
I think, pregnancy care doesn't happen in, the 14 visits over 9 months. It happens so frequently and all the moments in between. And so to deliver really great care, you have to support women and birthing people in those moments. And so it was so core to what we were building at Oula to be able to ensure that when the patient had a question, at 2 in the morning or 2 in the afternoon, that they felt like they could get connected to really great care. But to your point, you have to sort of be creative with the payment paradigms that exist in the US, which is we have a fee-for-service driven healthcare system, which means you sort of get paid to not always do the right things. And so for us, we were like, well, how do we get creative? If we know, for example, that something that's really powerful for women during care is actually community, right? As much as you want your provider to be an expert, you learn from other women. It's actually one of the things that have been demonstrated to drive down preterm birth outcomes. And so we offer group visits as part of what we do at Oula. It's I think it works because you have a provider spending more time with patients, but they're doing it in a group setting. And so it works within a very challenging fee-for-service landscape to be able to do something that is also really great for the patient.
Yeah.
So it's being clever in a lot of those ways. It's also why we invest in technology, and we use that as a way to say, what are things that we can do in our app, in our education, that is available for all women, and because you sort of build it once, it is much more scalable than always having to have sort of a one-to-one human interaction. It lets the time our providers spend with patients be really value add on the thing that they need to talk about in that moment.
Yeah, that's really interesting. And an undercurrent to all of these conversations is the inequities that we have in maternal health. It's very well documented that Black women are significantly more likely to have adverse experiences in childbirth and to die. How are you approaching that at Oula? How are you approaching health equity?
I think in a lot of different ways. I think one of the stats I like to say, because I think it really hits on why it's such a pervasive challenge, is that a Black woman who has a college degree has a higher likelihood of poor outcomes than a white woman who hasn't even gotten sort of high school diploma, which means there's just pervasive racism in our healthcare system, and it shows up in care, which means you can't really do one little thing and think that it's going to make a difference. And so we sort of attack that on a lot of different ways. One is we think about hiring, and we have hired a really diverse clinical care team. We know racially coded care results in better outcomes. But we also know the midwifery workforce, which is a huge part of how Oula delivers its care, is 90% white. And so it's not enough just to hire a diverse team. You also need to make sure that the providers who are on the care team who aren't Black have racial, implicit bias training. And we do it not just for our care providers, we do it for anyone who touches patient all the way up to the executive level, because decisions we make throughout the organization are going to show up and how patients see care. So a piece of it is really how do we build the workforce, and how do we make sure that they're examining their own biases and how it's showing up in decisions that they're making. I think the second piece is actually in like the care that we deliver and like the services that we design. And so we, for a while, actually did a postpartum support group that was just for our Black patients, and so they were able to do it in community. And I'll sort of pin that for a second because I think it kind of goes to the third thing that we do, which is we measure all of our data. We disaggregate it by race, and we say where are we doing well and where are we not. And we're looking at our C-section rates, and we're looking at our preterm birth rates, and we're looking at experience. And we're looking at our women showing up to that postpartum support group that we created. And when they weren't, we took a step back and we talked to our Black patients and we talked to our Black providers, and we used that feedback to redesign and realize it was actually too late. No one wanted to join it by postpartum. We actually needed to do it in the third trimester when they were like preparing and starting to think about what their postpartum was going to look like. So I think it's that sort of constant iteration cycle of saying, you know, we're not always going to get it quite right the first time around, but we need to show that we care and this matters, and we're going to continue to look at how we're doing and make sure that we're continuing to move the ball forward.
Yeah, and so right now it seems like Oula patients still tend to give birth in hospitals in a traditional setting, but Oula is very different. And what's that tension between, you know, this new model of maternity care and this old, you know, vanguard? What does that look like? How do you navigate that?
You know, I think in some ways the consumer's sort of looking for that, though. They kind of want the best of both. They want a collaborative care team of their midwife and their OB and the support, and they want to feel like they're delivering at a really great hospital, that if something goes wrong, they have all of the things that sort of traditional system has in place. So I think most people are looking for that. And I also think, though, when we're looking at who do we partner with, we're looking for a health system that cares about supporting patients and meeting community need and knowing that women want this. And so we work in close partnership for like, what does the care actually look like on labor and delivery? Not just what are we doing in our clinics or what are we doing postpartum, but how do we make sure the collaborative care experience that we believe so deeply drives better outcomes that the research shows actually plays through in sort of that traditional labor and delivery floor.
Yeah. And so how do you scale this model? How do you bring this to more people across the country?
I mean, we scale through partnership with health systems. We think it's so critical to bring sort of the legacy healthcare along. Like, we wouldn't be able to, I think, have as big of an impact if we were trying to do it all on our own. It really is about saying, what do we do that is excellent? And what does a health system do that is excellent? And how do we really bring that together? Which is, I would say, traditionally, like, you know, a health system is going to be great at really like high acuity care. When something really goes wrong, you want a hospital there. But also, what is so interesting about sort of pregnancy care is it's the one thing that you're going to go to probably where it's not a state of disease, right? It's actually the state of wellness, which is why I think it's often so hard for our healthcare system to do it well, and why you need a different approach and something like Oula. And so it really is about sort of, once again, bringing those two things together and using that as the way that we have really massive impact.
Yeah. What's the next women's health area that needs disrupting?
I mean, everything. Like, what doesn't? I feel like I'm so laser focused on pregnancy care that's like hard to pick my head up. And part of the reason why I think I'm so focused on it is because beyond the fact that any way you cut the data, it looks pretty terrible, whether it's maternal mortality or morbidity or equity, you sort of name it, it's broken. But it's also one of the most pervasive shared experiences women have, right? 86% of women become mothers. It's often the first time they're really interacting with the healthcare system, because hopefully, you know, you're in your 20s, 30s, like, you're pretty healthy, and then all of a sudden you're going to the doctor or the midwife, you know, 14 times over 9 months. You're getting admitted at the hospital, which means it's actually this moment in time to build trust with women and really change and shape the way that they access healthcare for the rest of their lives. And so I think it's just so important to get it right so that everything else, honestly, in their healthcare and that of their families, right? Women are making 80% of the healthcare decisions. So you really, if you do maternity really well, I actually think it pays dividends across healthcare outcomes and the whole sort of ecosystem.
Yeah. We like to end sometimes with one fun thing here at Axios, and I know that you and your co-founder and one of your other executive team members were all pregnant at the same time while you were starting Oula.
Don't recommend.
What is the biggest similarity and difference between birthing a baby and a company?
Yeah. You know, maybe at first blush it doesn't sound like a lot, but honestly, quite a lot. You know, I have a 7-month-old right now, and he was just starting to like learn to crawl. And what's striking is, you know, when he first birthed into this world, like I had to do everything for him, right? Change every diaper. Like he did not exist without me. And sort of true of the startup, right? Like it was myself, my co-founder, and a deck. And you're making every decision, you're hiring every person, but success in both of them is actually getting to a point where you're not doing anything, right? You're raising a child, like they need to exist without you. And sort of, I'd say that that's the same barometer for success for a company. It's getting it to a point where it no longer needs me.
Yeah, that self-sufficiency. Well, unfortunately, we are out of time, but thank you so much for joining us. It's great to get to talk to you.